I'm Julia. Thank you everyone for joining this event today. So as you know, the afternoon is split into two parts today. So the first part is around a PreCePT celebration and optimisation of the PreTerm infant event. So that will end at 2 o'clock. And then after a 15-minute break, we move into the PreTerm birth task and finish group with the idea that that starts at 2:15 and should end by 3:30. So this is the agenda for today. It was attached with the invite, and I believe it's also been circulated via email as well. So I'm not going to go through the agenda in any detail, but just before we start the event properly, I did just want to share this with you. So this is the MatNeaSIP driver diagram for the coming 3 years, and it's kind of hot off the press really. So as you can see, all the areas we're covering today are actually in the primary driver of improving the optimisation and stabilisation of the preterm infant. So I just wanted to mention that because it is quite new news. So that's really the introduction. I will come out of this and then I will hand over to Sandeep.
Thank you. For those of you who don't know me, I'm Sandeep Harigopal, one of the consultants at the RPI, but also the clinical lead for the Northern Neonatal Network, and also I was also the neonatal lead for the PreCePT program. I would first like to thank all of those who took part in this project, and I think we can safely say that it was a resounding success from where we started with the use of antenatal magnesium sulfate. There are a few people that I would like to thank, Karen and Julia, as well as Mark from the Neonatal Network, and Martin and Stephen for supporting us through this. So why is it important? I'm just going to briefly touch on why it is important and then hand it over to Karen, who will actually give us a little bit more of the audit data. Cerebral palsy is a major morbidity in newborn babies, and like you can see from this picture itself, you know, kids can't sometimes walk, talk, and have epilepsy and so on. So we needed to do something to try and see if we can try and reduce or prevent this. We also know that cerebral palsy is, you know, a major risk factor in preterm babies, and it can have a significant cost on healthcare, but financially, but also an unquantifiable cost for the families. But there was some treatment available though to try and prevent this, and in fact, there was a 40% reduction in cerebral palsy when they used antenatal magnesium sulfate in mums with preterm babies. And in fact, for every 42 mothers, you could prevent 1 case of cerebral palsy. So what was the problem that we had when all this began, or why did PreCePT become such a big project? Fewer than half the eligible women were actually getting magnesium sulfate at that point. And we needed to address this somehow. And when we looked at it locally, what was the issue with us? We had an uptake of actually just under 40% in 2016, and 2017 it was a little bit. It was about 60%. And I suspect there was some degree of data entry problems, but still it was a problem and a significant problem. So our challenge was actually to achieve a target percentage of 85% of all eligible mothers by 2020, which we are thereabouts at the moment. Not just on a single unit, but not just all our overall network, but in each unit. And we'll hear soon as to whether we've actually managed that. The journey was, we started a business case in 2018 July and had a launch event just less than 2 years ago, and in the meantime also prepared a network guideline primarily by Karen with the support of others, and also undertook audits, training, and data collections. And all this was supported by the Academic Health Science Network, including holding events for us. So if you looked at this nationally, over 2016 to 18, gradual increase in magnesium sulfate, still significantly low. Even by 2018, it was only 70%, and we were much lower than that. In 2018, where were we? We were still just above 70%, 73%, compared to the other networks. You can see that we were actually probably in the bottom half of it at that time. But where are we right now? So if you look at that right now, this is the latest data. So this is coming again from NNAP as opposed to our regional audit. It might slightly vary. We'll hear from Karen about what it is. But we can see that we have reached the target of 85%. So if you go back, we've gone from roughly 40% to 85%. We've almost doubled that. And even if you used 60, 70% is where we were, I think that was a significant improvement in our magnesium sulfate uptake. And I think we should all be proud what we've achieved in that time frame of less than 2 years. A lot of training has gone into this, and a lot of hard work from, I think, every midwife, everyone collecting the data, putting the data in, and so on. I've listed out, and in fact, we've slightly just over the national average at the moment, from being below the national average, much below the national average, to in fact above the national average at this point. So if we look back, what's happened nationally, and what PreCePT program has done, you can see the number of maternity units that have adopted PreCePT has gone up significantly. Over 1,000 more mothers have actually received magnesium sulfate, which means to say we were almost probably estimated that 30 cases of CP has been avoided during this time. And that is almost £24 million saving when it looks at the lifetime health cost. So significant cost saving as well. That's just financial, but I think if you look at it, for the families, that is a major improvement in the quality of care that we provided. So I think we can say, safely that we've probably had a fewer babies with cerebral palsy in our region, and also clearly improve the quality of care that we're providing for our preterm babies and their families. But I think it'd be useful to hear from Karen a little bit more about the audit data. So what I'm going to do is to now pass on this to Karen, and I will stop sharing my slide.
Thanks, Sandeep. Okay, so let's see if I can be as successful as you two. Okay, can everybody see my screen okay? Oh.
Yes, you just need to put your slides into full slideshow, Karen.
Oh, hold on a second. Is that right?
We can still see your slides down the side, so we just need to. Can you try using the little ones at the bottom? Yeah, I think it's.
Yeah, you just got there.
Yeah.
Oh, sorry. That one there?
Yeah, that's the one.
That one.
Oh, is that right?
The one next to the one nearest where it says 65%, so it's the one at that end.
This one here?
Yeah.
Is that right?
That's the button, but it doesn't seem to be working.
Okay, why don't you go to slideshow, on the top?
Yeah.
Yeah.
Right.
Oh.
Yeah. No, just go to from the beginning.
Yeah, that's what I had it on. It's on slideshow on my screen, but is it not with you?
No.
Well, I've had this problem before.
I have. I think it might be some. We've had this in the trust actually, so I wonder whether it's the way my laptop's set up.
Maybe. Well, as long as we can see the slides, I think just sort of.
Is that good enough for you?
Carry on, yeah.
Okay, so thanks very much for that, Sandeep. So I'm just going to talk about some of our successes, challenges, and how do we go on and keep this as business as usual in terms of giving magnesium sulfate. So Sandeep's talked a little bit about the success of it as a national project, and certainly the team were, as many of you will know, were shortlisted for a RCM award, and two of our midwives were actually drawn out of the hat to go down to attend the presentation evening for the RCM award down in London. This was obviously all before COVID hit us, and unfortunately that was all put on hold. I have some of you were very keen to hear whether we won that award or the national team won the award. Unfortunately they didn't this time, but they were really pleased to be shortlisted for it, and that was for the scale and spread of this project. So their latest figures are nationally, as a result of the PreCePT project alone, over 1,000 mums, additional mums, have received magnesium sulfate in the 2 years, 2018 to 2020. So for us up here, what does that mean? So it was 22 months ago since we first held our launch event for PreCePT. It was at Chester Street at the Cricket Club, and we had all of our lead midwives, obstetricians and neonatal representatives in the room. And I think that was a really positive event. I think we started off with a really enthusiastic, positive team to really launch this. We learned quite a bit more about magnesium sulfate that I think that we didn't know before. We knew it was a thing, but I think the importance of it really came home to us at that event. So following that, we developed our regional guideline, which everywhere is using, and we were able to share that on request kind of around the country, really. I think we were the first region to do that, and that was really well recognised by the PreCePT team. The next thing we did, when we had another one of our events, this time at the Durham Centre, we had some representatives, Lottie and a friend from Leo's charity, and we made some films involving them and some of you as well, and they went out over social media and again to the national team. So in the 22 months since we've been doing this project, over 250 women have received magnesium sulfate. Now that's not additional women, that's the women in total. So if we're looking at the total women that we've given magnesium sulfate to just in our region in those 22 months, potentially using, and I'm using slightly different figures to Sandeep, because actually what we know from some of the latest research is that we only need to give this to 1 in 37 women is the number needed to treat. So actually on that number, in this region alone, we've potentially prevented over 6 cases of cerebral palsy, which financially is over £5 million saved in lifetime care costs. But as Sandeep said, in terms of patient experience and the quality of life of those families, we can't measure that. And just recently, Julia and I have written up the project, and that's been published in the AHSN Atlas journal. So that again has been shared around the country. And I believe that we're doing a bit of work with Tom around some of the things that we've done with MatNeo in our region, just to share them nationally, because we've got some really good work going on.
So sorry, Karen, can I ask Julia here? To interrupt, it's just your slides aren't moving on, and we were wondering whether they were on your screen, but they're certainly not on ours. So sorry to interrupt.
No, that's all right. Is that moving on now?
Yes.
Right. Okay. Go there. So, so that's just the national success story, and there is just what I've talked through there. So I'll just leave that there for a second. Okay. So some really, really, really good work going on. So thank you to all of you again. Thank you. Just echoing what Sandeep said. So in terms of some of our latest audit data, so these are the results of the audits from April to July. So again, a very big thank you to Mark from the Neonatal Network, because on the 1st of every month he sends me through a chart with all of the details of all of these babies on. And then thanks to you, I send the audits out to you and get them back. So in April, we had 17 eligible mums, 5 of which didn't receive magnesium sulfate. So that gives us, in terms of what we look like in terms of our national data, that gives us a compliance rate of 71%. But by the benefit for us of doing this audit, we can actually see that where we possibly could have interfered and done something differently in these cases. So in the April cases, there was 2 BBAs. There was one case which was contraindicated due to maternal renal problems. And there was one case where it wasn't indicated because it was a non-viable pregnancy at 22 weeks. So actually, and we're still waiting for one audit. So a couple of these audits that we are still waiting for. One is due to technical difficulties with the IT system in one trust, and one is due to unfortunately our PreCePT lead being off sick at the moment, but hopefully she's back soon, and we'll be able to just pick up those missing audits. Apart from that, you know, we've pretty much got all of the audits back that I've sent out. So in April, we had 2 BBAs, one contraindicated due to renal problems and one not viable, and we're just waiting for one audit. So we're then able to actually look at our compliance in, I think, a bit more of a learning way, because actually 94% of women that were eligible in our region, and it was practical or decided to give magnesium sulfate, had it, possibly 100% if depending on what the final audit says. So similarly, in May, 16 eligible women and 3 didn't have it. One was, again, a non-viable pregnancy. One was contraindicated due to a placental abruption, and one was not in labour and then suddenly had a precipitate delivery. So we've gone from 81% on our national report to 100. June, we had 2 cases that were missed in June out of 12. One was a set of twins, one of which was born before arrival, and the second one was born 12 minutes after admission, and we're still waiting for the audit on the other case. And in July, I haven't got all of these audits back as yet, but the 2 I have got back, one was a BBA again, and one was contraindicated to an abruption, due to an abruption. So if we look back actually since April 2019, if you remember, we're aiming for 85% compliance, 95% if possible. And we can see that when we do the national audit, our compliance is still good. It ranges from, I think 67% is the lowest, up to 95%. So we're still doing really well. And as Sandeep says, overall in the last NNAP data, we've got an overall 86% compliance. So we meet that 85% target. But if we look at our compliance, if we exclude the reasonable exceptions, then actually we're fully compliant all of the time. Every case that we've had, or pretty much every case, gives us a compliance over 85% if we take out those reasonable ones. We are still seeing odd cases of data entry errors. When I'm sending the audits out, there's still kind of 1 or 2 cases a month where it's coming back that they did actually have magnesium sulfate. And this is important. I mean, it's not important because, you know, at least the patients are getting magnesium sulfate, but it's important in that we're not recording this properly. We're not getting the credit for where we're given this important drug. So I had to try and have a little think about what are our challenges going forwards now. And we're going to come on to the first bit in a little bit, just to check that we've still got the right people on our lists. And Julia's going to go through that afterwards. I think, again, in terms of the BadgerNet and the data, we've still got maybe some challenges around documentation, and whether we're getting it accurate on BadgerNet still and reflecting what we're actually doing in practice. Time. Have we got, I'm thinking more, have we got time to complete the audits? Are we getting the time to do that? Are we getting them back in a reasonable time frame? Are people supported still in trust to be able to do this job? Are we still getting the time to train our new starters that are coming through, and to really make sure that people are aware of it? And I think, again, thinking back to the wrong documentation, wondering whether actually we're getting it right with the records that we're giving on intrauterine transfer. Do we want to go back to the regional guideline and have a look at that SBAR tool and see whether actually, you know, our place is using it, our place is not using it? Do we want to do anything different? And I think the question to everybody on the call is there anything else, and how can we help? So and you may well have seen this because I did an annual report earlier in the year, but just a couple of cases where we thought we did have an opportunity to give magnesium sulfate, but we missed that opportunity. One was a PReMIP who had come in 27 days and 29 days with a UTI and pain, but wasn't admitted on either case. She came again at 29 plus 3. But was had a CGG and observations, didn't appear to be in pain, and the doctors were requested to review. It was handover time. There was other things going on. It wasn't highlighted as an emergency request to review immediately. And then unfortunately the patient was actually labouring quite quickly and delivered unexpectedly. So we missed an opportunity to get magnesium sulfate in that case. And the second one is a twin lady who was admitted with query labour and ruptured membranes. She'd actually been admitted for nearly 2 hours by the time delivery occurred. So she was given steroids in that time. And I think the learning from us still is to really plug the message that if we've got time to give steroids, if we're thinking about giving steroids, then think about whether it would be appropriate to give magnesium sulfate. Again, going back to the slide that Julia shared with you, this does need to be business as usual, and we do need to keep doing this. You know, it's not only part of the new MatNeaSIP driver diagram, it's also part of saving babies' lives and our compliance with CNST. And that's why really we've got this event to look at not just the PreCePT part of it, but to see how we can link this in with the place of birth and steroids, so that actually we're supporting you in the trust to comply with all of those elements of CNST. And again, saving babies' lives. So over to you, really. I think in terms of this, what are the challenges? Is there anything else that we want to do in terms of supporting you? Thank you.
So if anyone has any thoughts on that, please put any ideas into the chat box. That would be fantastic. And I'm just going to move on to leads confirmation. Let's see if we can everyone see that? Yeah.
Yes, Julia, that's working.
Yeah.
Thank you very much. So this is just really a really short slot. It's just a lot's happened over the past few months, and we just really wanted to check that our details are still correct, so we're contacting the right people and not irritating those who we shouldn't be contacting. So what we would really like you to do is just put in the chat box the name of your midwife, say what trust you're from, but then the name of your midwife lead, obstetric lead and neonatal lead, and we'll check those against the information we have already. If you don't have all the information, that's absolutely fine. Just put in what you do have, and then we'll chase that up and find out the additional information at a later date. So you don't have to do it immediately, but it would be great if you could put in the chat box the information which you know before the end of this session. So that's all I really wanted to say on that. I'm now going to hand over to Karen and Stephen. So I'll just stop sharing my screen.
I'm really hoping that it's Stephen that you're going to hand over to.
I'll hand over to Stephen.
Okay, thank you. Can I just see if I can share? Okay, can I just check that you can see that?
Hi, Stephen. Yes, we can see your slides.
Fantastic. Okay, thank you very much. And I think the first and most important thing I should say that many thanks and huge credit to Helen, who's actually undertaken an audit of babies that are born in the wrong place, for want of a better phrase, for some time now. Helen had the incredible foresight about 3 or 4 years ago to see that this was an important national issue and persuaded us to undertake a regional audit of all such cases, which was put in place really quite quickly and has worked very effectively since, and I think it's a huge credit to her. It's a shame she's not here because there is a depth of detail and richness to this audit that I'm not going to be able to do credit to. But I think she's happy that at least I share the bare bones of this with you. And actually what I would suggest that it would be a really great idea to invite Helen to a meeting of either the PreTerm Task and Finish group or this group again to talk in more detail about the slides that I'm going to show you. So I think you'll be familiar with the overall background to this is that it's been recognised as a key national indicator of quality of care. And we're now asked to review all such cases, and especially those babies that have been born, preterm babies that have been born in a unit without neonatal intensive care at less than 27 weeks. And the first message for us actually is that we do really well on this. This is a graph that for 2019-2020 financial year shows the number of babies that are born at less than 27 weeks who were either delivered in a unit with a NICU or in a unit with less than those facilities. Whoops, sorry. Oh, I've gone on too quickly and I'm not sure quite. Let me go back. And you can see that nationally, as Martin has told us, we really do well, and we achieve rates of in excess of 86% for babies at less than 27 weeks. And if we look at regions that are either close to us or even throughout the country, we're consistently top of the pile or near the top of the pile. Now, I think that reflects two things. One, it might just reflect in part the design of services across our area, with maybe, at least in the past, more services that offer neonatal intensive care per head of population than others. But actually, I think it also must be the result of some very high quality decision making that has been made in those units that don't have neonatal intensive care facilities. And actually, it just mirrors other things that we see whenever we look at our data closely. Then what we tend to find is that outcomes are actually pretty good, especially when we consider the disadvantaged nature of our population. So most of the presentation is going to be on the data that has been collected for 2019. Now, for 2019, there were 31 cases identified. For those of you with a sharp eye, you'd have looked at the previous graph and say 31 is more than you had in the previous graph. It is. That's because we chose as a region to audit all cases at less than 30 weeks rather than just at 27 or under. So we have a bigger cohort of cases to analyse. And again, actually, we have another really positive success story here. Now, what this graph shows is basically those cases that we've identified and those that we've audited right across for each month of the year. And I think that the striking things that you'll see from that graph is that we've actually been able to successfully audit almost all of those cases. And what's more, we've done it successfully throughout the year. It's not something that we've been getting better at. It's certainly something that we haven't been getting worse at. And I think that is a real credit to everybody involved, through identification of these cases and through actual audit and also collating those results. It's a massive credit to everyone that has done this. But of course, although there's some really positive messages, what we've also got to do is to say, well, even if we're performing well, is there anything that we could do to perform better? So what Helen has done is basically looked at those 30 cases and tried to see if there's any features within them or themes that develop that would allow us to say in the future, we could do better by taking different forms of intervention. And when she's done that, then I think the first thing that struck her was, as you'd expect, these are not cases that came out of the blue, and a significant number of these women have complications that you know are going to predispose to preterm labour, and certainly more. If you took 30 cases of women who are pregnant just at random, you wouldn't see a kind of distribution like this. So 6 women who had ruptured membranes, 4 who had twins, 4 who had preeclampsia. And interestingly, 1 who had a previous 20-week miscarriage. Now, throughout this presentation, Helen has written in coloured text a series of questions and suggestions. Now, I think all of the questions are really good questions and deserve the opportunity to be discussed. What I would suggest is that we take all of these to the preterm birth task and finish group for an opportunity to discuss them in a little bit more depth. And the first one she asked was, she found one woman who'd had a 20-week miscarriage and is clearly therefore at high risk, and should we, in our audit, actually include a question on cervical surveillance. And I think that seems a really sensible suggestion. It's a little bit more work, but only little. But I think we definitely need to discuss that in a next meeting of the preterm birth group. I think what was also a feature of this group is that quite a few of these women had admissions prior to delivery, and it's actually a feature, I think, with a lot of pregnancy complications and things like stillbirth. If you look at women who experience them, a lot of them have been into the hospital on several occasions before. In some of these were multiple admissions, and some of them were relatively quickly before or relatively soon before the delivery. Any features of those previous admissions? Well, 4 were for abdominal pain without cervical dilatation, with a real mixture of cases there. I don't know about you, but I have to say I don't always think about testing for preterm labour in women who present with abdominal pain where you don't think that they obviously are in labour. And I think one of Helen's questions, is this something that we should be considering? And I think that's a very sensible question to ask. 3 of these admissions for women with query SHROM. It's a real bugbear of mine. It'd be interesting what people think. Quite often I feel to myself when I'm on call, I'm not sure that I'm any better at looking after women with suspected SHROM than I was when I started all of these years ago. And I think there are several problems that you can see with women who come in with suspected rupture of membranes. I think one is, despite all these sticks that we've got recently, which are undoubtedly helpful, we can still get it wrong. And I think another feature of these women is that when they do labour, they can labour extremely quickly. But what can you do about that? Clearly, we can't keep women in hospital indefinitely. And you see the learning point that Helen has suggested from that as a key message. Is that we really consider ensuring advice to women to return immediately if symptoms worsen. And by that, I think she means that basically if women come in with suspected SHROM, we say we don't think you have, well, please come back if you think you might have done again. Or if you have gone home with SHROM, if you think anything at all is happening, then please get back to us as quickly as you can. A couple of admissions for women with antepartum hemorrhage. I think that is interesting because I think increasingly, I think as a group, and certainly, I feel this, if I see or ask to see a woman who's got an APH, it's not a huge APH, she seems absolutely well, all the indices of well-being are fine, maybe you can even get a scan and that's fine. I think increasingly inclined to consider going home rather than routine admission. But we've got to be aware that sometimes bleeding, even if it is minor, is a sign that something is going to happen. And I think with 2 of these women that had small or relatively small APHs a few days before they did go into labour, and we missed the opportunity to transfer them. So Helen is asking, is this something that we want to look at? Do we admit women who are bleeding, or do we want to try and in some way rationalise that? This was an interesting series of 4 women, so 4 women who we weren't able to transfer, whose primary problem was hypertension. And in a couple of these, you look at them and think, well, what on earth could you have done? These women that needed to be born within 4 or 5 hours of admission with really uncontrollable blood pressure. But a couple of them, maybe there were opportunities for these women to have been transferred. So these are women that were that gave birth 2 and 4 days after relatively early pregnancy admission with preeclampsia. What's the message from this? Well, I think it might. It is difficult, isn't it? Because by definition, if you are admitted to hospital early in pregnancy with preeclampsia, that is severe disease. But on the other hand, quite a lot of women, at least in the early stages of this, don't seem that unwell. And if you transferred all of them, you probably would be transferring quite a few women quite a long time before they actually gave birth. Maybe the message is something along the lines of, if you've got early onset preeclampsia, if you show any signs of deterioration at all, you're probably going to go downhill quite quickly. And I think that's the basis of the underlying message from Helen is, should we be considering at an earlier stage transfer of women with preeclampsia if they show any signs of deterioration. Another feature that was looked at, which I think is interesting, reasons not to transfer, and 2 or 3 things I think to pick up from this slide. One is awaiting medical review. There was a 2-hour delay from requesting medical review to this woman being seen, and that is uncomfortable reading, I think. Now, we all know there would have been a good reason for that. The person that was asked to come and be involved must have been doing something else that was vitally important. They weren't able to get there. But maybe it is something that we need to start looking at in a little bit more detail. And maybe we shouldn't shy away from the fact that delayed review of women can sometimes have significant consequences. Difficult to know what, if anything, you can do about that. I think one of the things that I've often wondered about is escalation policies. And you can have a situation in a unit where one part of the unit, whether it's a delivery suite or it's clinic or it's an assessment unit, is desperately busy. And is there anything more that we can do to try and redirect resources during the day and be a little bit more flexible about where staff are according to what the levels of activity are throughout the unit. But it's a really difficult one. Now, what Helen has done has had a look in a little bit more detail at those women who were in relatively advanced labour, and also looked at how long there was between those women being in labour and giving birth according to what their cervical dilatation was, and looking at it according to whether they were more or less than 8 centimetres. And you can see that there's an interesting message from this slide, and in particular, if you look at the women who are less than 8 centimetres on admission, and there were 6 of them. And the interval there until them giving birth was, if you take cut off at between 3 and 4 hours, and then 5 of the 6 of them, there was 4 or more hours until they gave birth. And again, I think this is an area where I could look back at my own practice, and when women have been admitted and have been 6 centimetres, I think there are occasions when I said, no, we can't transfer them. That would be far too risky. And actually, maybe we could, and there is actually quite a significant body of evidence in the literature that says you can successfully transfer women at what appears to be relatively advanced stages of labour. But clearly that is difficult because of the potential consequences of giving birth in labour. So you can see, sorry, in the ambulance. So you can see Helen's question there, which I think is a really good one, is should we talk a little more about whether or not we can have criteria for whether we transfer women in labour, including some kind of assessment immediately before they're transferred, if we want to make that as safe a policy as possible. This is a slide that just looks at the outcomes of the women. There were clearly significant complications to stillbirths, which is what you would expect. This is a very high-risk group of women, and I think this slide just emphasises those. So this is a summary of Helen's presentation for the 2019 data. And you can see at the top, and I think that really is worth repeating, 90% completion for a survey of this type is absolutely fantastic. Questions to consider adding to the performer and consideration points, I think it would be really sensible to take those to the preterm birth group, and the key messages there summarised, and we went through those as we went along. I wonder if we ought to think of some way of getting those out into the wider obstetric community. Maybe we could send them out as outputs from this particular meeting or from the preterm birth group. But I think they are well worth sending out as important messages that have come from this audit. Now, I'm not going to say very much about this, but there's just one really interesting feature of the 2020 data that I think is worthwhile sharing with you. Now, the 2020 data is so far incomplete, as it would be. So there's been 23 cases identified so far, and 15 audit pro formas have been completed. So this is a work in progress. But just to flip to the last slide of this that Helen provided, which is quite interesting, which is to look at the number of cases per month of the year for 2019 and 2020. And you can see for February, March and April, there were significant loss, substantially more cases during those 3 months than there appeared to be in the corresponding months last year, and certainly more in March and April combined that there was in the majority of the months last year. Now, whether this is just random variation, whether or not this is something going on, and clearly there's something going on that's in our thoughts at the moment, is coronavirus, I think is difficult to say. I think this is just something that we can keep an eye on, and I guess we would expect it to trend back downwards. I have to say I'm not aware in the conversations that we've been having about significant concerns from women who've had COVID and have either gone into preterm labour or we've delivered them. But on the other hand, the numbers aren't huge, aren't they? And it would only need 1 or 2 in each unit, and that would, when we take a wider look at it, that would end up to a significant increase, even if it isn't immediately apparent to any one unit. So I'll stop there. Huge thanks to Helen for doing this, and a huge thanks and credit to absolutely everybody who has been involved with this audit. I think it's a fantastic example of regional working and regional collaboration.
Stephen, it's Julia here. There are some comments and questions in the chat box.
Yeah.
Maybe we could have a quick look through. Starting with Martin at 1341, I think. Have we any sense of intelligence as to whether these pathway exceptions are routinely case reviewed at the PReCePT role? And Helen has done an outstanding job of going through the case notes to identify these potential ones that might have been managed differently. But is that then translated into a local brief? Is there any comments you would like to? Karen's made some further down, but I wondered whether there was any comments you would like to add on that.
Yeah, and the honest answer is I don't know if each of these cases will have had a internal case review as compared with them being accumulated as part of this audit. And it's a good question. I think it's one that we could ask through the preterm birth and finish group. And I know we've had discussions before following the national recommendation that each of these cases need a review with an external clinician present. And I think we've argued that to some extent we fulfill that brief anyway, because we do in some ways review these. And we review them in a forum in which there are external clinicians present, but it might be that we want to go beyond what we currently do, if there is an enthusiasm to do so. So I don't think they automatically would get reviewed in the sense of it being regarded as an adverse incident and having a case review. But there might be others that might reflect my lack of knowledge rather than the actual reality.
I think that it's just Karen here, sorry. I think that reflects what Joanne Dunn was saying, was around actually we don't necessarily have a trigger for reporting these to Datex because, you know, if they're appropriately, well, I don't know whether we do or not, but I mean, we would review cases and take them back to our perinatal meeting, but I don't know, Joanne's shaking her head, I don't think we automatically have a Datex trigger to report them.
Yeah, I mean, I think you could. I think that would be a really good thing to discuss. We've kind of touched on it before, but never really come to a consensus, and never, as a region, agreed we would definitely do that, and left it up to individual units to make the decision as to whether they do so. But I think it would be a fantastic thing to do if there was a regional appetite to do that.
And Joanne has raised her hand. Joanne, do you want to ask a question?
It's just to give a bit of further clarification around obviously having the ability to flag these sort of events, and it's something that came up within our local trust recently, where we've gone back, looked at our maternal baby trigger list and tried to ensure that you know, the triggers also were taken into consideration with the regional guidance that we've always had. But certainly from a multidisciplinary point of view, we've come together with paediatricians, and quite often, being based at Darlington and Durham, we do have to send our babies out to the tertiary centres for further care. So we do pick up on this, and I agree with Karen that it is discussed within the monthly perinatal meetings, but I just feel as though sometimes we probably need a little bit more depth of analysis within these cases. And is it something that we need to think about bringing together within region, and then at least we can ensure that the relative learning is being shared? We took this idea to our monthly family health quality and governance meeting, and Anne Holt was particularly interested in that we speak about this within the forum. I don't know whether I'm going to be able to attend the task and finish group because I have another commitment, but you know, I think it's something that we really need to work on regionally, and would you know, gain an awful amount of learning for the local trusts like us that transfer our babies out.
Thank you very much for that, Joanne. And Karen's got her hand up too.
Yeah, just to say, I totally agree with Joanne, and I think we had talked before about possibly theming our patient safety meetings around the 5 elements of saving babies' lives, and actually bring in, you know, the SGA cases, for example, to one of the quarterly meetings, and the place of birth and the PReCePT and steroids maybe to another one, and that, you know, whether that is a logical and a reasonable forum to bring them to.
Yes. Stephen, before we move on, do you have any comments to make around the discussions there?
No, I think that's a really helpful discussion. I mean, if there is a good feel from this meeting that we should recommend that these cases, or at least less than 27 weeks, are a trigger for a Datex review. I mean, I wonder, Julia, if that is something that we could include within the output from this meeting. I mean, clearly Helen's already identified, I think, some good learning points, you know, and we could include within those an ask of individual organisations that they at least consider that. I don't think we could necessarily mandate it, but we could at least ask that it's considered.
Yes, we can certainly discuss that further. So yeah, That sounds like a plan. Just before we move on, Martin's got his hand up, and then we really will need to move on to the next. We're running out of time because of these interesting discussions. Martin.
Apologies. Yeah, it was just, I think Shilpa's raised quite an interesting point in the chat room there that was kind of like possibly because of time not addressed, but I just think it would be interesting because she's basically making the point, you know, if they assess a mum in one of the DGHs and then they do transfer them IUT to one of the NICUs, and then, for example, they settle down, you know, they've just had a bit of niggling or whatever, and then they then send them back to the community. Quite often, a lot of these will then go back into labour, and the pathway at the minute is obviously they just go back to the hospital that they would have been expected to deliver at, i.e. Gateshead. But I think what she's asking here is there any way to kind of like sort of expedite a pathway which would see them go straight back to the NICU rather than having to come to the skipper, if I've understood Shilpa's point correctly there, which I think is a fair one.
Yeah, thank you, Martin. That's what I was trying to raise, because quite a few preterm babies that we've had and we've transferred out to Sunderland and RVI at the review meetings, that's the first question they ask is, we've been discharged from RVI, why couldn't we go back there? And that's the conversations we've had amongst the consultants and the team, that is there a pathway that we could create where the preterm baby mums could go back to where they've been reviewed? And that's a question that I need to ask at the network, and I'm sure Sandeep is there, just to think about a pathway, if that's possible.
Yeah, I think that's a fantastic point. Sorry, Sandeep, were you going? I mean, I think as you know, Shilpa, the issue there is it's just closeness to home, and you know, are there circumstances where it would be better for a woman to go quickly into a local unit and be assessed, as opposed to take a longer journey to get to a referring unit? But I think looking at that and trying to come up with some means of rationalising that on an individual basis, you know, because if a woman books at Durham, but she lives equidistant between Newcastle and Durham, then you could say it actually makes perfect sense for her to go to the RBI or whichever unit we're talking about, rather than to go into Durham and be transferred. So I think that's a fantastic area that we could look at and do some work around. Lovely.
Thank you. Thank you, Stephen.
Right. There's some really interesting discussions going on there, and I feel terrible about cutting it short, really. But just trying to keep to time. Can we hand over to Sandeep to talk about steroids? Sandeep, would you like to share your screen?
Thank you, Julia. Yeah, can you see my screen?
Yes, we can.
Thank you. I was asked if we could talk about steroids as one of the other areas that we could possibly improve upon. Well, this basically comes on the back of the MatNeaSIP program, or if you like, Maternity and Neonatal Safety Improvement Program that was recently named. And the aim of this program, like you all know, was to support and improve quality and safety of the maternity and neonatal care across England. And they had 5 drivers within that, and one of them was to actually optimize and stabilize a very preterm infant. I think we were reasonably successful with the antenatal magnesium sulfate part of it in terms of optimizing and optimizing the preterm infant. And we wondered whether we need to look at antenatal steroid and see if there's something that we could do. But the aim of this session effectively was to create some awareness around the data, which some of you might already know, but also generate some early discussions and see if there are any areas to improve, or we may come to the conclusion that actually, well, we're actually doing reasonably well. So why are we interested about antenatal steroids? Clearly, there is associated with significant reduction in neonatal death, respiratory distress, as well as IVH. And in fact, it was so good that the Cochrane collaboration took on that used the forest plot as their logo. But not only that, it's also associated with the reduction in necrotizing enterocolitis, respiratory support, intensive care admissions, and early infections. So a lot of good things that come out of antenatal steroids. And in fact, there are some studies that show that even as low as 22 weeks, there is some reduction in death and neurodevelopmental impairment. And I think it's something that's worth discussing, because we often find that since the change in the gestation criteria recently, the 22-weekers don't seem to be getting steroids for some reason. And I think that's a separate discussion, but it's something that's, I think, we need to bear in mind. I can think of at least the last 3 cases that we've had in the RBI who've not had steroids at 22 weeks gestation, despite them being in the hospital for a few days. Not just the RBI, sorry, across the region. Another reason is BPD, or bronchopulmonary dysplasia, or chronic lung disease. It is a significant morbidity, and almost a third of babies less than 32 weeks can develop BPD. And this is national data. But that's quite variable across the unit, and you can see some of them reporting as low as 10%, which is, a little bit, you wonder how it can be so low. But on an average, that's the national average, and there are some units that have much higher BPD rates. What about us in our network? This is so here in our network, you can see the red arrow, which shows another neonatal network, and when we look a couple of years ago, the BPD rates were up to 50% and then around 40%. So we were much higher than the national average. And in fact, the highest in the country at one point. But when it was corrected for treatment effects, which I won't go into detail, we were still in the, the higher end. We were not the highest, but still in the higher end. There's no direct correlation between BPD and antenatal steroids, but we know that antenatal steroids has an effect on respiratory outcomes, and longer periods of ventilation can result in chronic lung disease. So again, there's an indirect relationship between the two. So what has happened with the administration of steroids in the country over the last, say, decade, roughly? It's gone up gradually from 75% up to now about 90%, which is a good thing. And one of the reasons that it is also, you can see also, is that the missing data has actually come down quite dramatically. So in fact, nationally it's down to 0.5%, but I think regionally we need to make some improvements in terms of that. I think we are sitting at about 2 to 3% missing data, which we need to work on. What about networks, and where do we sit within that? So I've looked between 2016 and 18, and on the side is a national average. So the first box is the 16, second is 2017, and third is 2018, and you can see that from an average of 87%, we still remain the same, but the national average is gradually just creeping up, and as a network we slowly dropping down, just marginally though. And then we looked at 2018, and there was a further drop to the lowest in the whole country, by 6 percentage points, which felt quite significant. And I then went and looked at it a little bit more in detail, sorry, this is another slide. So this one basically tells you that wide variation within neonatal units across 2018. And again, majority of them are above, 90%. There are 90%, but there are a few that go down to 50% and 60% and so on. So yeah, so this is the slide. It's kind of a repeat slide. It's basically showing that the Northern Neonatal Network, our average was at about 80 or 85% or so. And when I looked, we broke this down. One of the reasons why that happened was, again, the high ones in red and highlighted are those with less than 90%. And we've had 4 units. And it was RVI which had a significantly lower, compliance, just under 70%, and that was very surprising. Showing steroids not given in 30%, and missing data also quite significant. So there was a audit undertaken as a result of that, as a result of this. And what the audit then showed was that it was probably not entirely true that it was so low that it was 70%, but probably higher, and it was most likely due to data entry that we were so low. But I think the point we need to recognize is that there are two issues. One is what they get, but also the fact that these things are published, and then we will turn out to be the lowest in the country if we get wrong data in. But I'm glad to say that I've looked at the last 6 months and we're doing quite well. So we've got our antenatal steroid uptake at 92% with a national average at 91%. So that's good. So that's a significant improvement. And I think that's part of it was down to some work that we did in terms of data entry. In the same time frame between January and June 2020, you can see that that 68% of the RVI has gone to close to 90%, and I think that because of the total numbers of cases that come here, it's bumped up the total average significantly. And there was only one unit which small numbers of eligible mothers had a 50% uptake, and I think it's worth going and reviewing why that was the case. And how did we fare over the last 5 years? If you look at that, each one of those columns are basically looking at the year, and then you've got all the units across the bottom. And it depends on where we think our aspirational target is. If we think, are we above 80%? In general, we could say yes, that's pretty, yeah, most of it is. If you're looking at 90%, we're probably just about touching it. But do we need to be looking at a higher percentage? What are the real contraindications for steroids, and could that amount for more than 5%? And if not, should we not be sitting at least 95%? Should not every mom not get steroids? Because we're not looking at, unlike magnesium sulfate, we want to get the mom steroids, because at least we know IVH has a reduced, even if it's not just RDS, IVH can be reduced by giving steroids, even if you don't have the 24 or 48 hours time frame. So I don't know what people think about it. Do we think there's a problem? I mean, if you just take the last 6 months, we'll say, well, no, there isn't. We've got a pretty good uptake of 90%. Or do we look at it and say, well, actually, yes, there isn't a major problem, but we could certainly do better at that, or we should try and work and do better. And if that is the case, how can we get better? So that was just a very quick run through of what I wanted to say. Let me just stop sharing there. Okay. Right. So I've finished there.
Thank you, Sandeep. If anyone has any thoughts on that, please do add the information into the chat box, and we can make sure that we can have a look at that. And I'm now going to hand over to Karen.
So really, it's just for me just to sum it all up, I suppose, and just to say thank you to everyone for all your hard work. I think it's very clear that these 3 topics that we've talked about very briefly today are key to not only to the good care for the mum and the babies, but actually key to some of achieving a lot of our safety actions that we need to do. And by coming together and sharing them together, actually that ticks a lot of boxes for us, and a lot of learning. So I think to leave everybody with two asks, please, 2 jobs to do before we catch up again. One is please to confirm those leads to Julia. And I think really it's making sure that, our clinical directors and heads of midwifery are aware of these roles as well, supportive of them, because actually there is, if we're going to do this and we're going to continue to do this and share these lessons and learn from them, then we need to have the investment in this in terms of time and support for our leads in the units to get these audits coming through, because the more we can get out of them, the better. And I think my second question is regarding the audits. Currently we are doing very well at auditing all the missed magnesium sulfate cases. Currently we are doing very well at getting that really good information through Helen for the place of birth audits. Is this now an opportunity to look? We've got these, 3 very clear directions from the national team about the things that we need to look at for optimising preterm birth. Do we need to review these audits and incorporate steroids into this process, or do we need to review the questions in the audits? Are they giving us the information that's important to us to enable us to share and learn from them? So I think that's my question for all of you, really.
Right, so does that bring us to the end of this meeting?
I think so.
Right, well, thanks ever so much for your time. It's been really interesting, and we could have spoken for a lot longer, I think. So thank you for that. Well, thanks again, everyone, for your time, and thank you for so much for all your hard work, which you've been doing over the past year or so and longer. So I'll see you all soon at the Task and Finish group. Bye for now.
Thank you.